Hello, everybody. Welcome. David Willis here from the Center for Study of Social Policy and our Early Relational Health Coordinating Center. Welcome to our June celebration of Willis and Friends on this first day of summer. So welcome. As you know, our Early Relational Health Coordinating Center at CSSP seeks to advance early relational health across early childhood systems and communities to make visible this scientifically based, meaningful, and impactful approach to partnering with families, especially around a racial justice, anti-racism, and health equity frame. All of our efforts are to bring about this paradigm shift in child health care to focus on relationships and the power of relational healing, recovery, and promotion. It's always a delight for me to share with you my most valued friends and colleagues, national thought leaders who all inspire me as we all work to advance this understanding of early relational health, the paradigm shift, the framework, all of this about focusing on health equity in this movement first. So let me talk today about our context of today's session that I've entitled Advancing Early Relational Health in California, from ACEs to Resilience. California Governor Newsom's vision for early childhood has included a comprehensive child development programs for education, health, and family strengthening with groundbreaking boosts in early learning efforts and foundational changes in clinical child health for young children and families. Then the governor appointed Surgeon General Nadine Burke-Harris, who brought an unprecedented leadership and vision to elevate the needs of children who experience toxic stress and how that unfortunately disproportionately impacts children of color. She championed a statewide initiative to screen and identify adverse childhood experiences, to advance transformational efforts in child health care in communities, to mitigate those impacts by intentional supports, especially around safe, stable, and nurturing relationships. That inspired state innovators and visionary leaders to advance this work. And that's who I've brought today for our dialogue. I'm so excited to have my dear friends Alicia Lieberman and Dana Long, who are joining us. Their influence in California has been dramatic. Their influence nationally is really important, and their friendship means so much to me. Let me tell you about each of them first. I'm delighted to have met Alicia Lieberman when I was a 0 to 3 fellow. I was inspired by her, and I so admire her contributions. And I consider it just an honor to have worked together, to be thinking about how do we advance early relational health in this journey to advance our work. First, when I was at HRSA around the home visiting space, then when I was at Perigee Fund, and now in our journey at CSSP. She's the Irving Harris Endowed Chair of Infant Mental Health, Professor and Vice Chair of Faculty Development at UCSF, Department of Psychiatry and Behavioral Sciences, and Director of the UCSF Child Traumatic Research Program. She directs the Early Trauma Treatment Network, and she is a senior developer, as all you know, of child-parent psychotherapy, relationship-focused treatment for traumatized children. She's an author of numerous professional books, treatment manuals, articles. I remember first meeting her with her book she wrote, The Emotional Life of Toddler, many years ago when I was in primary care. And then, of course, her work around attachment vitamins that continues to really inspire me. She's a recipient of numerous awards, and including most recently a Lifetime Achievement Award with 0 to 3. It's just an honor, Alicia, to have you with us today. And then Dana. I first met Dana Long when I was at HRSA because I discovered her Find Connect model, which addresses social and environmental factors affecting children's health outcomes. I think I called her, and I think we had a conversation. And then when she was visiting in DC, giving a small group gathering, I think it was a campaign for grade level reading in CSSP, I went over to the meeting and listened to her presentation, fell in love with her and her thinking, and especially on the Find Connect work and then all that's gone on. I then was visiting at Stanford and went up to see her in Oakland, met at her clinic, and our relationship has built from there in terms of our now co-developing this early relational health movement and really moving this work as a collective impact effort. She's a primary care pediatrician at UCSF Benny Hill Children's. She's co-director of the Center for Child and Community Health. Her career has been dedicated to eliminating childhood health disparities and was led for issues to address poor health, financial and educational outcomes for children and families to improve individual and population health levels. She's co-principal investigator of the PEARLS study and also the Find Connects model. She's on the steering committee of First 5 Alameda County, Help Me Grow, has a number of advocacy roles, a number of awards. And Dana, I just learned today that you're a consultant on the TV series This Is Us. Oh my gosh, about bringing early relational health to TV series. So, it's such a great honor to have both of you today. And so let me start our conversations with just a comment and then your response. Let me begin. In our introduction, I commented about exciting progress that has been made in California to advance policy and practice into the child health sector. Identifying adverse experiences and toxic stress. Be intentional about educating a clinical workforce about interventions to mitigate stress by strong, safe, stable, and nurturing relationships. But all these new policies are actually advancing early relational health in California and the transformational processes. Each of you has been involved in this good work together, individually and separately, and together. And I'm really interested in your thoughts, your observations, your reflections on that journey, how you think what you've been doing is really groundbreaking and guiding, leading this movement of early relational health for improving child and family well-being in communities. So Dana, can I come first to you and then Alicia, then to you? So Dana, welcome.
Thank you so much for that wonderful introduction, and being able to be part of this conversation with you and Dr. Lieberman is just an honor. And just like This Is Us is about the big three, this is our big three. So the journey to really understanding early childhood adversity and the benefit, strength, the solution orientation of early relational health work, it started for me in about 2012, 2013, when I started working on a project to think about how are we screening families for unmet social needs within the context of the primary care home. These initially were unmet basic needs like food or housing, the need for transportation or diapers or access to green space. I had the good fortune of meeting Dr. Burke Harris, and in 2016, we launched the PEARL study at our clinic at UCSF Benioff Children's Hospital in Oakland. We're a federally qualified health center where we wanted to think about the initial ACEs, which are abuse, neglect, and household challenges, and really pair them with the research that I had been doing with my colleagues about unmet social needs and drivers of inequities such as discrimination, community violence, housing instability, being forcefully separated from your caregiver, whether it's from deportation or immigration. The combination of Dr. Burke Harris and my work led to the creation of PEARLS, which we then took a deep dive into the scientific space as we did a randomized controlled trial to not only do face and statistical validation of the tool, but also to pair it with interventions that could either prevent or mitigate the harmful effects of trauma on young children, all focused on a strength-based perspective for how are we actually supporting and showing up in community. Through an amazing series of events, beginning in 2019, the state of California, through the Department of Healthcare Services and the Office of Surgeon General, working within Governor Gavin Newsom's California for All initiative, launched ACEs Aware. And the goal of ACEs Aware was really striving to create a better world for children, families, and communities by working together across health, across human services, across the educational sector, and nonprofits in order to prevent and address the impact of ACEs and toxic stress within California. And ACEs Aware brought together communities in ways that we had never imagined before in order to prevent, screen, treat, and heal trauma-induced toxic stress. Particularly, my focus is on children. So the PEARL screen was created for 0 to 21-year-olds. And we hope to be able to get to the root cause of some of the most harmful and persistent and really expensive health challenges that we're facing our state. In 2021, the ACEs Aware movement really migrated from being solely held within Office of Surgeon General and Department of Healthcare Services to being anchored within the academic structure of UCLA and UCSF. Into what we are calling UCAN, which stands for the UCLA UCSF ACEs Aware Family Resilient Network. Which is bringing home the academic work of ACEs Aware to develop, promote, sustain evidence-based and evidence-formed methods to screen, treat, and heal from the impacts of toxic stress and trauma.
That's phenomenal, Dana.
I will pause there because I know that was a lot. I do want to just really focus on the fact that we are leveraging community partnerships as well as clinical and educational expertise that we have across the University of California, theoretically to screen and respond to ACEs. But as we all know, when we screen for ACEs, we have to practice cultural humility. We have to practice trauma-informed care. The whole approach needs to be strength-based in terms of how are you caring for the caregiver and the child. And so much of this, especially in the early years, is listening to families, showing up authentically, being able to let families know that you're in their corner, that you are rooting for them always, and to be able to connect families to networks of care so that we can address those unmet basic needs, but also attend to the social and emotional well-being of the adult in that relationship as well as the child.
That's a great start for us, Dana. And Alicia, can I come to you and your first thoughts about the journey that you've seen and witnessed around the work with Governor Newsom, but also the ACE Aware work and the like. So what are your reflections and thoughts?
Well, I'm just very excited to be dovetailing with Dr. Long in this wonderful journey and meeting you, David, Dr. Willis. My journey started earlier. About 25 years ago, I was asked to start a program at UCSF focusing on actual trauma that happened to young children. And we know that the first 5 years of life are the most vulnerable in children's lives. More children die of accidental injury or actually child abuse, such as shaken baby syndrome, in the first 5 years of life than at any other time. And together with that, we know that young children have very rich inner lives, that the capacity to trust adults, feel protected, feel joy in exploration and learning, unfold in the first 5 years of life. And so when trauma and adversity happen and burden the family, the impact on the child is enormous. And the trajectory towards healthy development, loving and learning gets disrupted. And so my team and I developed a treatment called child parent psychotherapy that now has 2,000 rostered clinicians nationally. We're in 46 states, plus DC, 6 countries, 70 national trainers. It's really expanded. And it's been an enormous satisfaction to see the extent to which people have opened themselves to understanding that relationships between the parents and the children and between the interveners and the family are the key to healing from adverse circumstances, which occur disproportionately among families of color who are disproportionately exposed to racism, discrimination, marginalization, lack of opportunities. My program, I'm happy to say, is the only program in UCSF that is majority ethnic and racial minority clinicians. So we really practice what we teach in terms of dual focus on developmental needs and on cultural humility and learning from the families what they need. About 15 or 18 years ago, I met Nadine, Dr. Burke Harris, through a marvelous grant called the Tipping Point Mental Health Initiative, where we were located in her pediatric clinic. And she would see her little patients and their parents and see the extent to which adversity interfered with the health of the young children. And so we were on site at her beck and call to be brought in to talk with the families about what do you need, what can help you, how can we be with you in your goals of bringing up a healthy, happy child. And she wrote about it in her wonderful book, The Deepest Well. And we wrote a chapter together with the clinician and the supervisor for the case that describes an actual intervention in the context of this idea that pediatrics and mental health need to coexist, be together, be co-located. And that became an early route for what now has become the triads model, which is the result of a grant that she gave to UCSF, that Dana is Dr. Long. May I call you Dana since we're friends? At UCSF, where there were 50 clinics throughout the state of California using what we call triads, a triangle that consists of trauma, resilience, intervention, distress, and strengths, where we bring protective factors to bear on the question of what happened to you, how is it affecting you, what helps you, who helps you, how can we join among the factors that help. And that has become a very well accepted way of doing relational screening for ACEs, because from the beginning, our approach has been screening for ACEs by itself is not the answer. Is bringing it together with how has it affected you? How do you understand the connection? And what are you finding in yourself and your community that has really helped you to bear the difficulties in your life? And how can we add to it and join with you as allies? And that is, I think, where we all come together, the use of relationships as a way of moving forward.
That's been so inspiring. And I know, Alicia, when we were at that gathering about the Pearls tool, and you and I were talking about the criticalness, and that was at the very beginning of the state's ACEs Aware initiative, and thinking about the criticalness of relational promoting and positive childhood experiences, right along with identifying those needs and adversities. And Dana, I'm really curious, how have you thought about the impact of all of this on your clinical practices and what you've been witnessing for pediatricians in California as they've been learning and leaning in with Triad on the training, with the Pearls effort and the like? Can you talk about what you're seeing in practice change?
When we think about practice change, I think the implementation of ACEs screening, response, and triads as a framework has been transformational. It's been transformational for the system, like the healthcare system, that is really thinking about how do we center family voice and patient experience and do that in a way that is anti-racist and culturally humble. How do we also hold the clinicians to be authentic and reflective? And how do we then operationalize the scaling and sustaining of these efforts? And each of those tiers, there's been just profound change. I want to hone in on the effects of triads on clinicians, we were not trained in medical school to be reflective. And what Dr. Lieberman has been able to bring into the conversation is this notion of reflective supervision and how does this impact you and the way that you are relating to your families,
Mhm.
and how does it relate to what you're hearing and experiencing, and then how are you actually supporting that entire unit. And if I may, I would like to share sort of my reflective session that I had with Dr. Lieberman, which was very altering for me personally. And everybody can watch this. We can put the video in the link for this discussion. So we hired a company to help produce these videos of clinicians actually working with families and implementing the screening and the response process. And then we sat down and we all watched it together. I mean, Dr. Lieberman, myself, and as well as the patient actors. And what came out of that conversation for me was to think more about how am I in that moment, including the caregiver in the process of talking about hard things and experiences that might have happened to the caregiver themselves beyond just what happened in the life of the child who is my patient. As pediatricians, we often think that the child is our patient, right? But with EHR, we're moving to understanding that the dyad is really the patient that we are treating. And something that Dr. Lieberman pushed me to do more is to think about how am I seeing, how am I acknowledging the experience of the parent in the moment of screening for ACEs and her visible response to answering the questions on the behalf of her child. And it doesn't have to be complicated, is what I learned. We think that in order to support parents, it's going to extend our 15-minute visit. We're going to have resources for the parents. And the truth is, what was suggested to me was simply to say, I hope that you take as good care of yourself as you do your child. Right? And by saying something so very simple, it allows it to be known that you care for that caregiver, that you see how hard that caregiver is working, that you want to support that caregiver, and that you are there to support both of them. And so when I think about triads and what it's done to transform pediatrics, it really has challenged us as providers to understand and embrace that you don't have to be a therapist to be therapeutic, right? That we are enough in that moment to hold the conversation and to respond.
Now, all of this has been going on during COVID. And I'm really curious about what has surprised you under the pressure of COVID that we've all experienced and clinics have experienced and families have experienced on one hand. Secondly, the relational pressures that have been real in terms of families and people and communities and neighborhoods taking care of one another in the midst of this revolutionary thinking about adversity and taking care of oneself for the benefit of the next generation. What have you been seeing? What are you thinking about that has surprised you in this period within your good work in California? Alicia, thoughts?
You know, I want to refer to the way Dr. Long was speaking. Her warmth, her tone of voice, her facial expression, which came through in Zoom. And I think that she really represents what it is that we want to convey with this approach, which is that how you are is as important as what you do. And the way that she was speaking to this young mom with a young baby, the sense of embracing her in her care through her tone of voice, through her body language, really came through and comes through in Zoom just as much as it does in the actual person to person. So I think we just saw an example. And amazingly, many clinics are reporting fewer no-shows because transportation is such a shameful problem here in this country. So that families that do not have means now, with the enormous increase in the cost of gas, but also with the difficulties in public transportation, families with many young children, let's say, with 2 buses, etc., and work and everything else that they have to do, the idea that they can do this on Zoom can be such a relief. And I don't know whether that has been your own experience, Dr. Long, but it has been our experience with many of the clinics that we work with.
I think this is why Dr. Lieberman is such a master, right? She's able to make everything a teachable moment, which is just glorious to witness. And I agree with you. I feel as if in the pandemic, we have learned how to remain connected to families via telehealth. And I also, to answer your question, David, I also think that the pandemic has ripped off the Band-Aid to the pains that we have in this country, so that most everyone understands or has experienced some degree of trauma. And there is a real willingness to lean into the pain because we all have experienced it.
Dana, can you talk more about that? What are you witnessing clinically in practice? As you say, the exposing of the depth of pain, suffering, trauma, and challenge, but also a recognition of relational supports and connections that really matter. What are you witnessing in clinics? What are you hearing from families?
As frontline providers, we have banded together, literally. We have had to lean on each other in order to get through some of the roughest times that we have had as practicing clinicians, through the uncertainty of COVID and the fears of our own safety, but also the fears for the patients that we see. I have also seen how the relationships that we have with families have carried us all through, right? Those relationships are meaningful to us as I think we are to the communities that we serve. And that's been very powerful to watch. Families have trusted us as primary care pediatricians to get them through these moments. They've trusted what we've said about prevention. We've had a lot of conversations about vaccination and what that means for adults, what it now means for kids, now that the COVID vaccine has been approved. And so I've seen us weather the storm together, is sort of the summation of what I would say, and that it has solidified relationships amongst and between us and our patients and each other.
And Alicia, from your view, what have you seen in terms of clinical practice change, especially this integration of all of this thinking into a new way of thinking about the medical home and communities? What are you witnessing?
I think what Dr. Long said about us coming together and realizing that we really need to move beyond the silos of our disciplines, because families experience a variety of stresses that each of us can enter through our particular perspective, but we need each other in order to help in a coherent, holistic way. And the fact, for example, that there are children who are not seen in schools, and who use the primary care setting as their lifeline for help. And then if they can reach out to a program like mine, for example, or other programs in the behavioral health community, to come in and join forces, is, I think, where we need to go. And again, my colleagues and I have seen a real decrease in no-shows in mental health appointments. And we have continued to have long waiting lists. There is a shameful scarcity of social workers, psychologists, psychiatrists who are trained in childhood, and particularly in early childhood. I think infant and early childhood mental health is still kind of a latecomer in the training of psychologists and psychiatrists and social workers. But I think that that is why this kind of setting, like what you are doing, David, is so important in order to spread the message that we need to work across silos and we need to incorporate attention to young children in anything, everything that we do.
I appreciate those comments and so agree. And also how we distribute this knowledge, this heart, this stance of caring about the carers, all families, deeper into communities. I think a lot about how communities have resiliency within them for healing. I think a lot about how the stance of some community health workers and doulas play a role to supporting and helping families grow. And Dana, I'm thinking about your resilience clinic, and if you could make some comments about that. And then Dana, and then Alicia, I want to come back to you about the perinatal PCC. I want to talk about that perinatal because it's so meaningful. But Dana, first, could you talk about the resiliency clinic a bit?
I would love to. So the resiliency clinic was born out of really wanting to create a place for children that have experienced trauma and who are screened for ACEs and PEARLs. How can the medical home, the primary care setting, really help to promote mindfulness, self-regulation, and co-regulation using a group visit model of pairs of dyads coming together, usually 4 to 8 dyads at a time, that is based upon sort of language, English and Spanish groups that are staffed by a primary care provider, such as a nurse practitioner, as well as a therapist and a community health worker. And in those groups, we create a curriculum, 6 to 8 weeks, and it is focused about understanding the science of trauma, how it affects our bodies physiologically, and how we can actually build the tools in our tool belt in order to not make all the trauma go away, because we're never going to be able to do that. But how can we actually alter the way that we respond to that trauma, and that to feel more connected and engaged in our environment? So the Resiliency Clinic is for young children, 0 to 5-year-olds. It's been amazingly successful within our clinic. The feedback that we've been getting about the group visits is that parents wish that they had it sooner. They want to keep going. They want to bring other parents along to the journey, because what also happens is social networking amongst the group. And so we recently had a reunion of our first set of families that participated in the Resiliency Clinic. And it's been just a great success and really needed. As you know, we have a shortage of mental health care professionals. And so thinking about the primary care setting as the nidus for innovation and for group visits, it's been very, very successful.
There's so much there, Dana, to unpack and to learn, lean in on, and to learn in that whole transformation of the medical home being a healing, recovery, resiliency, and building activity. I think about the centering parenting movement of similar ilk, or the resiliency clinic, thinking about the strength that people together, talking, sharing, exploring. To me, those feel actually very natural, and also very culturally, historically meaningful for people to counter the isolation. And I think that your work and demonstrating that is really, really powerful. Similarly, Alicia, when I think about the prenatal CPP work, the moving into pregnancy, resiliency and strength, I think especially with the doula movement and the community health worker movement, how the learnings from perinatal CPP can really help us in terms of addressing the depth of trauma that surrounds and both communities, and is so powerful in pregnancy, but a great opportunity for healing through that period, all in keeping with this relational health healing frame. I wonder if you could talk more about that.
You know, the thread that Dr. Long described in terms of making the primary care setting the place where people find their emotional needs also met applies so well to the theme of pregnancy. We have evolved, extended child-parent psychotherapy to pregnancy and the perinatal period, partly as a result of a study that we did at San Francisco General Hospital in the OBGYN, the Women's Clinic, where we found an enormous prevalence of depression and PTSD in women that came for their prenatal care, and yet they were not receiving services. And when we asked them, what the study started with flyers on the bathrooms of the women's health clinic and next to the elevators and so on, saying, "Are you pregnant? Do you want to tell us your story?" And so many of these women said to us, "I never knew anybody was interested in my pregnancy. I didn't know anybody was wanting to hear my story." And we pay them for 2 hours. Often they stayed 3 and 4 hours. And often they told the interviewer things that they had not told anybody before: sexual abuse in childhood, domestic violence in pregnancy. And they said, "I feel lighter, that now I can feel like you heard, and that you help me understand that this depression, this PTSD, these symptoms that I have are not because I'm crazy. It's because of what happened to me." And some of them asked for treatment, but many of them said, "I just understand myself better. I don't need any more." So I think it goes back to what Dr. Long was saying, that it doesn't need to be intensive, prolonged. It can be being there in the moment and saying, "I hear you and I see you and I help you understand that what happened to you, of course, has an impact. No wonder you don't want to go out of the house if you saw community violence last week, that you want to protect yourself." One of our therapists, Marquita Mays Barrido, the way she was working with Nadine at the time, she went to a home of a woman that was not coming for her pediatric care, and she said, "No wonder you don't want to go out. It's really dangerous out there." And the woman said, "You are not blaming me." And that became the port of entry to a really wonderful partnership with a failure to thrive baby who started thriving. We're doing that in pregnancy now. And about the group process that Dr. Long was talking about, Marquita Mays Barrido developed a program called Embrace, which she calls a love letter for Black mothers and their partners, which is using Black culture in groups to talk about what she calls safe passage, which is a metaphor, right? It's a safe passage created by the group, processing their experience of pregnancy together. And what they say at the end is, "We want more. We don't want to end what this is supposed to end. We want to continue." And in perinatal child-parent psychotherapy, it's for women who need more intensive intervention because their depression and their PTSD symptoms really interfere even with their ability to be in groups. And it just floods them. And talking to them about how do you feel about this pregnancy? Something like 40% have told us that they don't really want this pregnancy. And so the idea of reproductive health and justice have to also become part and parcel of our activism for giving women the opportunity for creating the family size, the family spacing that they need and that they don't always have access to.
It is so moving to me to think about and to hear. I think about Dan Siegel's comment that said, what's shareable becomes bearable, and countering that silence, and how our health system, rather than judgmental, asks or acknowledges, and then we create the structures where people can tell their stories and feel valued and heard. It's so much of the healing process that we're talking about in the transformation. Of course, it requires that reflective practice space, right? And
Right.
Dana, it makes me wonder, how are you encountering, or also Alicia, how are you encountering primary care docs thinking about reflective practices themselves, their own reflective experience in the journey of the last few years with pediatricians or family practices or clinics? Have you seen growing, opening dialogue, open reflective space that practices are creating?
So I definitely want to hear Dr. Lieberman's response as triads is scaling across the state of California. I can share briefly my reflection is an immense openness and a willingness to try something new and different because we know what we're currently doing isn't working, and a desire to be better and wanting more and not necessarily having the understanding about how to operationalize it, how to get time protected in order to do the practice of it, and really needing mentorship and guidance.
Alicia, your thoughts?
We have the same experience. And I just want to say, this brings back, Dr. Long, the time when I met with you in the East Bay, and you told me that before teaching providers to administer the pearls, you have a retreat where you talk with them about what's your experience, affect you, and finding that connecting with their pain and hearing you show interest in their pain made them feel like the woman who said, "You lifted my spirits, now I see the connection," right? And I think that in turn opens them, because we see that there is so much burnout among primary care professionals and among mental health.
So as we wait for Alicia to come back on, Dana, what do you see on the horizon? What's on the horizon? What's exciting you about as this work's moving forward? What are you seeing?
So much is exciting me. This unparalleled opportunity that we have in the state of California with the alignment of policy, practice, and budget in order to make real change in terms of the screening and the response to trauma, and the building up of resiliency. Our goals are to advance the science of not just ACEs and toxic stress, but also the science of resiliency. What works in order to support families? We are currently funding practices. We have pilot grants out to both community organizations and healthcare systems, to think about how do we bring family voice in? How can we better support sustainability? How are we measuring impact, and how are we actually demonstrating that by having the hard conversations and responding, we are improving the health outcomes? So I think there's a lot to look forward to right now.
Alicia, I had asked Dana, from your perspective, what's on the horizon? What excites you? What are you seeing leaning in to this moment in time? What are your thoughts?
I think exactly what Dana said. It's building on this momentum. This is just the beginning, right? We just opened the door and we're finding this enthusiasm. We have 65 agencies in line asking for training on perinatal child parent psychotherapy. We have one trainer. So workforce development, right? Would you both agree that workforce development in terms of both in uh, providing workers already in the field with these skills of self-reflection and openness to the reflection of others, bringing that into the workforce, but also in the pipeline, creating more opportunities for this kind of approach early on in medical training, in medical school, in pediatric training, in psychiatry training, in psychology, social work training. I think we really need to be in the continuum from early intervention to in work, in job service, because we really need all of us, and we need an army of people equipped with these skills to continue the work.
I so agree. And even in a broader sense of communities and populations, I think about how all the wisdom that we have here can be further activated in the communities and the people themselves. Like, for example, I heard today from a colleague, Jessica Riggs at University of Michigan, where with the early relational health screen, which offers families the opportunity to make a movie, turns the camera around and asks families to comment on what they see in a reflective stance. That simple movement of a family's reflective experience themselves of what they thought was sweet in the relationship has impacts over time. People discover by reflection some of their own strengths, which really jumped out to me in thinking about community building, thinking about activating this relational reflective frame in all young families and in communities, and how our community health workers, our doulas, and then our connections through the medical home can play powerful roles to shift the narrative to be relationally centric and reflective. And I'm wondering about how each of you think about that at the larger population and community change level. Alicia, you want to go first? Your thoughts? Maybe Dana?
I was just thinking as you were saying that about how phenomenal your work is, Dr. Willis, with the Center for the Study of Social Policy, in terms of having a platform to communicate and explain what we are trying to achieve. There is not yet a consensus definition of early relational health. And then once you have a definition, how you are actually integrating that into practice. And so I think certainly you have leaders in the space. Dr. Lieberman is like historic and incredible and super has built out the field of childhood trauma. You have the work that's happening in California with ACEs screening and response. But in order to change it into a national movement, the work that you are leading is just so critically important to get it into the popular media in terms of incorporating lay people, in terms of making sure that families and communities are centered around the work. And I can't wait for us to be able to publicize the definition that you've been working on through your consensus process.
That's phenomenal. Alicia, are you able to lean in? Looks like there are some technical issues there. So Dana, to you, again, You and I have been talking about next generation physician training. We've been thinking about what will the future child health clinician look like and how do they partner deep with communities and families. You want to give us some of your reflections?
Right now, we do not have a standard way in which early relational health is incorporated into medical school, residency, and then even early faculty training and mentorship. So it we are going through a process together, you and I, of creating work groups across the country to actually look at what medical school curriculum does look like and to see how we can insert this definition of EHR into that curriculum and then make sure that we are practicing that, and adding that component of self-reflection in is going to be critical. We are early on in that journey, but I am hoping that on Willis and Friends, give us at least 6 to 8 months, and then we'll be able to report on how it's going.
And Alicia, it would be true to say that your contribution of it has to be a reflective process in a parallel way of us as clinicians on one hand, then offering that opportunity for sharing that with families on the second hand, and then third, encouraging families' own reflective space of that baby and their relationship itself becomes really, really central. Your thoughts about future here that we're trying to envision for the next generation of child health providers? What are your thoughts?
We are working with community providers in different states through state governments to really bring to community behavioral health the idea that children need to be served in the context of their family relationships.
That's right.
And that the old paradigm of individual treatment for children is outmoded and ineffective, or insufficiently effective. I don't want to say ineffective because children do improve when they're given a setting. But the point that we want to make is that children do not need a therapist who understands them unconditionally and makes a space that is separate from the family space. Children need a family that protects them unconditionally, and where the adversities and stresses of the family are compassionately understood, not as obstacles to the child, but as real hardships that the adults have that interfere with their emotional availability, with their time, with their energy, because people are fatigued, they're overwhelmed, and where the family together needs to come into an understanding on what do we want for ourselves as a family. And I have to say, when we tell 3-year-olds, your mommy cannot give you the breakfast that you want every day because she has to go to work. And when she goes to work, she can buy you clothes and she can buy you toys and she can, it's like, and so something that little, and the parent is like, oh, I have the right to say that's what there is for breakfast. And this is just a little example, right? Where 3-year-olds think that what they want is what they need. But in fact, we need to help them realize that the parent is giving them a lot and not always everything that they want. I think that that family context, family therapy, family-oriented intervention needs to happen across the board. And that is really my passion for children of all ages, but particularly in the first 5 years of life.
Exactly. The relational health framing of all things we say in support of and encouragement of the relationship health itself, regardless of the external challenges that make it harder and the misinterpretations that are so often in place if we don't reflect well ourselves. I know we're coming to the end of our time together. I would like to give each of you a few minutes for any closing thoughts, both of our conversations or also closing thoughts you want to leave with the audience as this moves forward. Dana, you want to go first?
I think that what I'm seeing amongst my colleagues is the need for us to feel as if we are making a difference in ways that are tangible to families, that understanding that early relational health is a solution to a lot of the struggles that families are having, and that we have the ability to communicate with families in ways that are effective and sustaining for them. It's just really important right now. And in order to do that, we need the framework and we need the words to know what to say. And so I'm looking forward to being part of that, right? Being able to share the words, to share the framework so that we all can be healthier.
That's so good. I'm glad your dog concurs with us as to the importance of these conclusions. And we might wait another moment because Alicia may be able to jump back on to finalize with us. But Dana, this has been an incredibly good conversation. And Alicia, I'm glad you could jump back on. Any closing thoughts you want to add before we finish today?
It's such a privilege to have had this conversation and to be in the same geographical location as Dr. Long and to be collaborating in this way across the bridges, right? And across the disciplines and building bridges. And with you, David, putting relationships at the front of everything that we do. Relationships among ourselves, relationships with the parents, relationships with the children, building tapestries. And also, I think, the way I protect myself from burnout is remembering that life is really a chiaroscuro. It's a combination of light and shadow. Mm-hmm. And that helping families think of their adversities and their stresses as part and parcel of the human experience. And the fact that there is growth after trauma, that trauma often connects us with spiritual values, with aspirations, with sources in the community that bring the memory of beauty, of connection, of togetherness, of higher values, is where the hope comes in. And I think that for everything we do, we try to end our encounters with families with a note of hope, leaning in, as Dr. Long said, into their pain, leaning into their pain because people need to be heard and seen, and then reminding them of the source of pleasure, joy, love that they told us about, so that it is not Pollyannish, but it is hooked to who they are. And that reminds them that they are complete human beings and that pain and joy are constant partners in our everyday life.
Alicia, thanks always for taking us to what I hold in my heart is that hope springs eternal. And hope springs eternal with the birth of babies and the next generation. Yes. And we're witness, and we have opportunities to share with families their experience of those discoveries. And so what a great conversation today. I'm very honored to both of you to be my friends and to have conversation together. And I hope the audience likewise has found the pleasure of our conversation together shared out across this this platform that's virtual, but yet captures hearts, captures eyes, and captures souls. So thanks for your time together, and I wish you all well. Bye-bye.
Thank you.
Bye-bye.